coating and typically have 3 screws in their series, there was potential for loosening. I couldn't find detail on the weight-bearing status afterwards, but they did not directly bone graft the joint, but used these screws that had a bone graft window. And then there was a short case series of 4 patients with revision of triangular implants. And these were revised from triangular implants that showed some loosening around the implants, mostly on the iliac side, that were then revised to these screws that used the, I believe, technique where minimally invasively the joint was decorticated and bone graft was placed. So similar to the old trans 1 technique. Again, 4 patients that were revised with reasonable success rates in the literature. One other article that I thought was interesting and worth mentioning was what to do with the implant that is irritating neurologic structures, irritating the nerves. In this case, the implant was into the foramen, into the canal where the S1 nerve was passing. And they were able to, instead of revising the implant and pulling it out, go in with an endoscope and basically burr away the end of the implant while protecting the nerve, and showed what they described as a successful outcome in this patient. So again, failures can be from loosening, but they can also be for other reasons, such as neurologic irritation. Briefly, I wanted to just mention a little bit about the importance of thinking about the fusion and thinking about, are we just stabilizing the joint with implants, or are we fusing the joint? And what are the factors that go into this? And in my mind, there's patient biology, there's stability that we provide, and then the bone grafting material that we use, whether it's autograft or synthetic or otherwise. So again, when you have a failure, a pseudoarthrosis of the joint, you may have poor patient biology, poor biomechanics. Maybe the bone graft choice was not ideal. Maybe it was compliance. And I know the weight-bearing status after surgery is certainly debatable, and how quickly patients should return to full weight-bearing is certainly debatable. But maybe there was poor compliance, or maybe it was just bad luck, because not all perfect surgeries have perfect success. So again, there's a lot of factors that go into the patient's biology, and all of these factors, I think, are ones worth considering when we're looking at revising an SI joint fusion. But patient's biology might be the age, might be mechanically how they walk or how they function, or the stress that they put on. We know nicotine interferes with bone healing, diabetes, poor nutrition, especially vitamin D, can interfere with bone healing. And then we talked a little bit about compliance. And then also we need to remember that whenever we're considering a revision, what's the likelihood of an infection in that site? Is that potentially a source? And I would add to this, some infections are really very indolent. We're finding more and more now with spine hardware that's removed, even if you have beautiful solid fusions and you take hardware out, we are finding bacteria on that hardware that we don't expect. No signs of gross infection, normal lab results, but bacteria that seems to find its way to hide on the surface of metals that may or may not play a role in healing. So again, biology, remember that NSAIDs and nicotine have significant interference with bone healing, especially with NSAIDs at early stages of healing. The inflammatory stages in the first few weeks, I think, is most important. But we don't have great data on how long one should avoid the anti-inflammatories. Nicotine, of course, everybody knows has an extremely high rate of interference with bone healing. And stopping smoking for my patients is required before any kind of fusion surgery. Vitamin D as well. We've been hearing about this for a number of years now, that vitamin D deficiency is significant among people in general, but especially with all of our fears of skin cancers. There's so much avoidance of sunlight that vitamin D numbers are surprisingly low. And then, of course, osteoporosis, which is always considered. And remember that there are ways to treat patients before surgery. So if you're considering a revision in a patient with osteoporosis, Forteo and Prolia, the teriparatide and denosumab, and then there's some newer ones that that are out now that are worthwhile and worth considering. Typically, I leave that up to my endocrinology partners, but is always a consideration before a revision surgery. Again, we can both improve bone health before surgery, and these may also help with the bone healing itself and improving of the fusion success rates. So when we talk about biomechanics, we also want to think about the implants, and this is what we often focus on. And is it a matter of the wrong implants with inadequate stabilization? Is it poor positioning or too few implants? Again, those are the questions that we ask when we're evaluating a failure. And with those biomechanics, I think it's important to remember that the pelvis is not just the SI joints, but it's the entire pelvic ring, both the SI joints and the pubic symphysis, to give that ring its complete stability. And again, it's this 3-joint ring that is stabilized with all 3, not just one joint at a time. Excuse me. So again, achieving stability of the SI joints might require stabilizing the whole ring, and I suspect that we could debate the need for stabilizing all 3 joints. So how do I go through assessing patients with potential SI joint failure? You know, starting with verifying the diagnosis is I think paramount. We need to know that it's the SI joint and not something else or another source of pain. And I think Dave will talk a little bit more about the physical exam versus CT scans and injections, but imaging and injections play a big role for me in evaluating the failure. Once you have verified there's a failure, the question is, why did it fail? And that's, again, patient biology. Was it the fixation? Was it the biologic material that was used? What can we do to improve our patients before surgery and minimize that risk of failure again? And then planning the surgery, again, implants is what we all tend to focus on, but what implants do we need to take out? What tools do we need to take those out? What implants do we want to place? And what bone grafts will we use? And then what part of the pelvis needs to be stabilized? Is it, again, just the one joint, or do you have to stabilize the whole ring? And then what's the plan after surgery? Will there be a special weight-bearing status? Will there be any nutritional supplements, anything else to do to maximize the likelihood of healing? So just to talk a little bit about the diagnosis, I think the history and the physical exam are extremely important. And the majority of the time, I can know with a high level of confidence. And I know Tom Freeman will stress the importance as well of the history and the physical exam. That really to get an extremely high level of confidence of the SI joint as the source of pain lies in those two. X-rays can help with showing signs of loosening, especially with some of the SI bone implants that have a lot of metal artifact. And certainly with cannulated screws, CT scanning tends to be ridden with artifact and more difficult to interpret many times. But X-rays can show haloing around the implants. Bone scans and SPECT CT scan type of imaging in this case is certainly very helpful, but not necessarily as specific. And then for me, injections, a CT guided injection helps to verify the diagnosis. It doesn't make the diagnosis, but it helps to verify the diagnosis. Again, what tools do you need for that revision? What are you going to use to take out the implants? What implants are you going to place? And will that be intra-articular or extra-articular? Is there a consideration of using old-fashioned plates? And then do you need pedicle screws to provide fixation between the sacrum and the ilium posteriorly? Do you need to stabilize the pubic symphysis? And are you comfortable with pubic symphysis plates? And then what biologic material will you use? So just the visual, of course, that goes along with the various tools of different options for revision. And then without taking up too much time, I've got a few cases to review to illustrate some of these lateral techniques that may or may not have been successful. So this was a patient that was a 44-year-old woman. She had an accident 5 years prior to seeing me. She was treated with these cannulated screws and had developed chronic increasing pain in the SI joint. So she'd had all kinds of conservative treatments. On physical exam, she had florid findings of SI joint pain and the typical history, and the injections did give her temporary relief. So here's an example of good patient biology, but likely not great fixation, especially in light of a significant trauma. The CT scan was very difficult to interpret. Hard to tell if this is just artifact or if it's haloing around the screws. But you can see that the joint itself was certainly unhappy. It's arthritic with anterior bone spurring. So again, old healed fracture, inadequate stabilization, no bone graft was used in the process, but the patient has good biology, and ligamentous function is unclear, but probably disrupted. So,
Diese Sitzung wird aufgenommen.
And so our plan was to remove the cannulated screws, and we used the navigation system to help us get down to the screws, and then remove the screws and replace them with the 3 triangular implants with the idea that this patient had good bone and good biology. Second case, this was a patient of mine where I treated him with one of my first SI joint fusion surgeries. He was a 62-year-old gentleman. He was a pilot, an airline pilot that had retired, had previous laminectomy, was evaluated for lumbar spine, could not find a good lumbar spine source of pain, evaluated for SI joint pain, and history and exam were positive. But injections were then diagnostic to verify the diagnosis. He was treated with the 3 SI bone implants placed with navigation, which I feel more comfortable with the navigation, but still over time, he had first a successful result, but 3 years after surgery, and I had seen him for 2 years after with good results, was completely happy and back to normal function. But 3 years after surgery, he had this flight with one of his friends that was testing some kind of plane, had some aerobatics, and felt immediate pain in his SI joint. So again, evaluation showed loosening of the implants, and my suspicion is that there was some loosening of the implants chronically over time, and that then was somehow dislodged or made a little bit unstable by that flight. So we could see the implant loosening on CT scan, especially that proximal implant had the most haloing around it. And so again, we started off with adequate fixation, adequate biology, and good compliance, but there was failure at high stress, and this was a patient where I had not bone grafted the joint. So my belief after seeing this patient and and treating him is that I find bone grafting the joint that much more important. So we made sure that we had the right removal tools for the implant removal, removed the proximal implant and replaced it with a screw. We tested the other implants to try to pull them out, but they were stable enough. They must have been solid either on the sacral side or the iliac side. And then we replaced one other implant and ended up with 3 implants and a screw, and then placed bone graft in the joint. And having that decorticated bone graft in the joint, I think makes a significant difference. So he was happy with the outcome and eventually had a nice solid fusion. Another example is a 42-year-old woman. This is a little bit more of an extreme example for whom we took some extreme measures. So it's a 42-year-old woman who had 2 previous surgeries on her SI joint, one that involved a direct bone grafting type of procedure with some type of a cage. And then subsequently, 2 of these SI bone implants were placed in a second surgery. This was a patient who is a smoker and who was somewhat overweight and had immediate post-operative weight bearing. And I think that then led to this failure, which showed significant degeneration of the joint and no bridging bone, but certainly the trauma from the surgeries. So, and then loosening of the implants as well. So again, poor fixation, poor biology in a patient using nicotine and obese, poor compliance. Maybe that was her instruction, maybe that was what she did on her own, but she was weight bearing right away. Probably adequate bone grafting, but I'm sure the ligaments were disrupted from either the surgery or prior. So recommendation from my end was to stop the nicotine, to work on her biology, and then look at fixation with bone grafting, but fixation of the entire pelvic ring with bone grafting to stabilize the pelvis. She chose not to return or not to proceed with that surgery, went back to a previous surgeon who added implants. And unfortunately, the additional implants also did not stabilize the SI joint adequately. Again, same picture of loosening now of 6 different implants and lack of success. So our thought process was that we need to be aggressive in a patient that's had extensive previous surgeries and a very unstable joint. So after working on the biology, getting off the nicotine, all of the nutrition, we proceeded with bilateral S1 screws, bilateral S2 screws, more of an S2 alar type of screw, and then 2 iliac screws with bone grafting of the SI joint and a pubic symphysis plating with our trauma partners who were very comfortable with pubic symphysis plating. So our goal was to stabilize the entire pelvic ring, and that was successful in stabilizing the SI joint. However, 2 years later, she ended up with pain in the opposite SI joint, and we stabilized the left SI joint the same way. Now, 4 years out, she's very happy with her outcome with a nice stable pelvis, and I won't say that she's running marathons, but is happy with the result of the fusion surgery. Finally, last patient example is just being sure that we have the right diagnosis. This patient had an SI joint fusion with the triangular implants in 2017. Came to see me with some continued pain, and my evaluation was that the implants looked good and were stable, but her pain was from the degeneration and the spondylolisthesis at L4-5 and L5-S1. We treated her with anterior posterior fusion surgery. She had a nice solid fusion, but continued to have this aching chronic type of SI joint pain. And we subsequently, now that the lumbar spine was healed, you can see on the bone scan and the SPECT CT images that she really lit up in that left SI joint. And so at this point, we were willing to believe that the SI joint was the source of pain and instability, and we revised her with direct bone grafting. The previous surgery did not involve direct bone grafting. And then exchange of one implant with the screw, in addition of another implant to get stabilization across the SI joint. So, and this is a patient that I thought would never be happy. We all have those kinds of patients, but she surprised me with how well she's done after this last surgery. So my general thoughts, I don't know if they're real true conclusions, but my general recommendations are that you really have to evaluate the patient for their biology and compliance with the treatment plan. You need to make sure that you've got a clear diagnosis, and if you have a clear diagnosis, you have a much better chance of success for any surgery. I think you need to have lots of tools in your toolbox of ways to both directly fuse the joint and stabilize the joint. And then really, to me, I believe that it's extremely important to get a direct bony fusion across the joint. I think that stabilization without fusion has a significant risk of failure at some point down the road. And you have to be prepared to stabilize the entire pelvic ring. I don't think that it needs to be performed that often, but there are cases where the entire ring has to be stabilized to get a good, successful outcome. And I will stop there and turn it over to Dr. Pauly.
Vic, thank you for, as always, your very thoughtful approach to this. I want to thank two people as part of my presentation. Mark Schwinkowski is the person who recruited me from the Army to Minnesota and was my department chair. He's the editor of JBJS and a trauma surgeon originally. And he's been the one who's done all of the anterior SI fusions with me. And then Levi Brown is one of our residents who has been working on trying to define our revision experience. My disclosures, which some of which certainly are appropriate and concerning for or affecting this topic. And so the first question is, what is the rate of failure? And so we know no procedure is 100% successful, and not all patients who fail radiographically need to have a revision. So I've had some patients who've had halo formation who weren't symptomatic. So who needs a revision? Well, someone who's symptomatic that, as Vic has told us, that we can identify the pain generator as coming from the SI joint. So this is a gentleman who was just recently referred to me from Idaho, who has probably the most profound halos that I've seen around triangular titanium rods. Interestingly, most of the time when I see this kind of finding around the ilium, it's been due to bony overgrowth over the lateral aspect of the implant rather than true loosening. So what's the published data on revision rates? Well, this is the best data that we have, and it's not a frequent revision rate. So that when we compare it to total joint replacement, we're probably in that same ballpark initially for the first year or two in terms of revision rates. So again, best data that we have, but it only tells the story for triangular titanium rods. From the lowest study, so 5-year follow-up on prospective patients, radiolucencies were seen in 6 sides, 5% of the patients only on the sacral side, and that in 5 of those 6 cases, there was probably an adequate length into the sacrum. And so that left 111 sides of implants were analyzed, and 109 had 98% of them had apposition of bone on at least 30% of the surface. So what about my personal experience? So this is our data review. So we had 67 patients who were identified by CPT codes, 22 of whom either didn't have surgery or opted out of research. So that gave us 45 patients and 50 SI joint revisions. And my revision strategy has evolved over time. The majority now have become the transiliac, so removing the lateral implants, bone grafting, then an open anterior ilioinguinal approach with typically through and through iliosacral screws. I've tried a number of other things that have not worked out well in my hands. Potentially they could work out well in others' hands, or potentially if I used Vic's matrix approach of patient analysis, maybe that would alter our thinking process as well. So here's the data that we have, and we're still working on trying to understand this. So the patients had ODIs. That's a routine part of our evaluation process. And you can see that after about 3 months, the majority of the patients reached a positive improvement in their ODI, but the aggregate score did not achieve a minimum clinically important difference. So they improved on ODI, but not MCID. The leg pain actually improved through about 6 months, and then either it's a selection bias of the people who still had pain came back for follow-up, or the leg pain got worse over time, and we can't answer that question yet. But you see that the follow-up certainly has dropped off at 2 years, and so I think it's the people who aren't doing well who regularly come back. In terms of back pain, we did in fact achieve an MCID starting at 6 months and continuing out through 2 years. And so it seems like we're making the back pain better, but maybe not the leg pain. And that may be somewhat related to our choice of doing the open anterior ilioinguinal approach and the issues associated with the lateral femorocutaneous nerve and the elevation of the iliacus muscle and potential hip flexor weakness or associated challenges. So ODI got better, but not MCID. Back pain got better and did reach MCID, and leg pain improved at 6 months, but worse at 2 years, and probably a follow-up selection bias. So my thoughts about my primaries where I did the first surgery that went on to failure. Probably didn't go long enough initially on the cephalad S1 implant. That turns out to probably be the most important factor under the surgeon's control. Sometimes we're only able to get 2 implants in. It's not common, but it has happened. Bone density at the sacral terminus of the implant, the post-op weight-bearing status, as Vic has already mentioned. When loosening occurs in the patients that I've followed, it seems to happen early, perhaps within the first 3 months. I can't say that I've seen late loosening. I've seen late symptoms, but not really late loosening. And then a lot of patients get referred to me for presumed SI problems who actually have flat back syndrome. And that if you were to just fix the SI joint and not fix the flat back syndrome, I don't think you solve the problem. So example of a patient and what I'm trying to do today, 3 implants, trying to get medial to the S1 foramen on the cephalad implants, trying to get a long engagement in the sacral side, which we're generally able to do utilizing the 3D navigation. I'm not sure I could be as aggressive in my implant placement if I was only doing that with 2D guidance. But we do encounter these dysmorphic sacra occasionally, especially in women, where the challenge is greater because women typically only have 2 sacral articulations, whereas men will more commonly have 3. and that this dysmorphic sacrum without a through and through channel presents more of a technical challenge in implant placement. And so in this patient, we could only get 2 implants in place, even with 3D guidance. And every once in a while, as I practice pediatric spine surgery as well, you get these congenital anomalies with partial lumbosacral agenesis that make any sort of work around the pelvis particularly challenging. So my personal growth through the revision experience started out with thinking like Vic did, okay, it's pelvic ring. And my simplistic thought at the time was if I just plated the anterior symphysis pubis, that ought to eliminate the motion and solve the problem. Well, I went 0 for 4 on doing that alone. Then I tried a series of the smaller shim implants and maybe had 50% success rate. Then I went to removing the implants, bone grafting the defect, and placing iliosacral screws, not typically through and through, but just across unilaterally, and had some success, but not particularly high rates of success. And then got to the concept of removing the implant grafting and through screws with an open anterior ilioinguinal approach. Much longer healing process, maybe slightly improved clinical results. So my revision strategy involves using a lateral lumbar spine retractor. I happen to like the Medtronic one because it's got a screw that holds it in place and makes it a little more stable. Then I can directly visualize the implant, remove the implant, and typically this is what they've looked like, well fixed on the iliac side and not well fixed on the sacral side. Then screws either with or without washers. We more typically are using plates like a 1 or 2 hole plate, as the washers usually aren't big enough to cover the area. And then an formal open anterior ilioinguinal approach in bone grafting. So let me share my best success case. So this individual works as a corrections officer at a local prison. You see he's had a previous L5-S1 fusion, and he does in fact have a dysmorphic sacrum, good bone stock, confirmed with a CT guided injection. This was what he came to me with from somewhere else, sort of a blobogram SI injection, and why I went to the CT guided confirmation. And here are his implants at the time of surgery. And so the first implant's fairly long, and I'd say good position. We got 3 implants in place into what seemed to be good bone stock. And here is his initial post-op image, 6 weeks, 3 months, and now we'll zoom in, and we're starting to see that not just the halo formation, because the halo formation can be due to something called Mach effect from the implant itself, but when you see a sclerotic reactive rind around the halo, I think to me that is the most compelling radiographic sign of loosening, and it's very similar to total hips, non-cemented total hip stems that have the so-called pedestaling effect. Confirmatory diagnostic injection, again, CT guided, confirmed, and we did the approach of remove the implants, bone graft. You can see the bone graft, so we impaction bone grafted the defects, and because of the dysmorphic sacrum, I could get a through and through at S2, but not at S1. So there he is, and he returned to work as a prison corrections officer with no job restrictions at all. He says he has no pain, and his ODI was 1. So he is my best result from a revision ever. So he is an example of things going well. And on the contrary, I've got some other patients. So this person who was treated at an outside facility, underwent an appropriate workup, had a different lateral screw-in device implant placed, and she had both sides done. Notice on the one side, she's only got 2 implants. And when you look at the CT scan, you see that one of the implants missed and injured the L5 nerve root. And she presented with a complex regional pain syndrome already present from that initial experience. So here's what her further scans look like. We did the CT guided injection. Both sides relieved her symptoms. Revising the implants, so using navigation to deliver the K-wire. Then we had to trephine these out because they were well fixed in the ilium, but not in the sacrum, leaving a fairly significant bone defect. And I said, well, I'll just impaction graft that. And I missed something. And the something was that they were lined up with the neural canal. So I nicely impacted bone graft into the S1 neural canal. I tried removing that from the same approach, did not do well with that, and ended up having to, so recognizing this and then having to go do a dorsal approach and trying to decompress it and being distinctly disappointed with my ability to clear out the S1 neural canal from posterior. Maybe if I was a skilled endoscopist, maybe I could have done a better job on that, but that was tough to do. And then place the iliosacral screws across with a resulting construct looking something like this. You do see the big hole that was left, and even with a washer or a plate, sometimes the screw is sinking into that defect. And so this is where she is, and that we've gone on and done her other side. And I would say her course has been complicated, and I'm not sure that I have made her any better. I'm not sure I had a better alternative answer at the time of her presentation, but that concept of paying attention to the alignment of the defect hole and the neural canal ends up being critical in thinking about bone grafting and do you impact the bone graft or not. She has gone on to heal, and so we have CT documentation of her healing of the SI joint, and that you can see that she's actually gone on to fill in where we did in fact do the impaction bone grafting as well. But the whether or not I aggravated things by the impaction bone grafting or not, I can't answer. So that is, I think, my major learning point from a lateral revision strategy. And then one more case, so patient with previous lumbar fusion, a little bit of flat back as well. Long discussion. The parameters for the flat back deformity aren't horrible. They're there. A little bit of a PILL mismatch and slight pelvic retroversion. Long discussion about it. Bilateral vacuum sign in the SI joints, some osteophyte formation, some irregularity. And this strategy going in and placing the implants. And so we got 3 implants in what I thought were reasonable position. Again, another dysmorphic sacrum. So that dysmorphic sacrum to me is just really a red flag about potential for trouble. And then over time, what we saw was, again, you start to, so we're now 3 months and we're seeing that loosening about the implants as well. And at 1 year post-op, now having more symptoms and progressing over time. And I think that I don't think the implants loosened this late. I think what happened was the halo became more evident, and whether that's radiographic projection or exacerbation of the halo, I don't know. So confirmation with the diagnostic CT injection, standard removal approach for me, through and through iliosacral screw. Again, with the dysmorphic anatomy, I find the 3D navigation very, very helpful. In this case, we had trouble getting the most caudal implant out, so I left it. And you can see the through and through screw at S2, and then because of the dysmorphic sacrum, just a unilateral approach iliosacral screw. And here we are with the follow-up evaluation and the filling in of the defect and subsequent pattern. And so I think the dysmorphic sacrum is a challenge, and I think revision in a dysmorphic sacrum is more challenging than in a normal sacrum. And that in a normal sacrum, this is my goal for screw placement, looks more like this. All right, and then to up the ante one level higher, this patient was referred to me who had a fusion and of the SI joint and the lumbar spine, and we see the thoracolumbar Scheuermann's kyphosis that I think was probably the initiating problem for her whole cascade of events. And here are the CT scans of the previous SI fusion. You can see the first one is in line with the S1 foramen, You see the second implant actually didn't engage the ilium, and didn't engage the sacrum, and the third implant didn't engage the ilium. And so she had a challenging anatomy to start with, but this certainly didn't achieve either the surgeon or the patient's desired outcome. Simultaneously with doing her spine revision, we removed her implants. Navigated K-wire. I couldn't unscrew them because they were the ones that were engaged in the ilium were well fixed to the ilium, but we were able to get them out, and the caudal one came out because it was only engaged in the sacrum, and that was easy to back out. So here are the actual retrieved implants, and again, the iliac portion is well ingrown, and the sacral portion is not. And so then we used the so-called bedrock technique along with our placement of S2 alar iliac screws and extending her fusion on up to get this resulting initial construct. And then here you can see from a posterior revision approach the amount of sacrum and ilium engaged by triangular titanium rods. And we didn't do quite as good a job on getting this quite where I would like it to be on the previously fused side. This is where she is now. She's doing better, but I think it's too early to call it success or failure at this point. So my experience has been that loosening occurs on the sacral side. Not all radiographic loosening is symptomatic. We confirm it by physical exam and injection. Revision strategies, tried a number of different ones. I have, as Vic has shown a case, I have a patient who we had plated anteriorly, put through and through iliosacral screws in and done anterior bone grafting on. She came to us having had 3 different prior SI fusions, and she's back to being a teacher, but that was a really long haul. And so that's me trying to tell you, in all honesty, my experience with revisions at this point. Happy to take questions.
Any questions?
So I have a question I have a couple of questions. Dave, with your experience with this anterior approach, you know, historically the anterior approach to SI joint fusion has been really had a negative connotation to it because of the morbidity and the potential risk of going anteriorly. Now, I know that an experienced surgeon can get in there well, but tell us a little bit about the difficulty of getting in anteriorly and how that approach works. Are you going under the iliacus? Do you end up with patients having pain or weakness related to that? Is it a long and painful recovery? How's that been?
So great question. We actually, I had one of my PAs look up our length of stay for these revision patients, and typically it's about 4 days. An obese male is the most difficult one to get in on because their pelvis is anteriorly directed instead of laterally directed as the females are. So the easiest revision would be a thin female. Mark Swinkowski does that approach for me, and he's quite experienced with it, and it's an hour and a half for him, and maybe 150, 200 cc's of blood loss, some of that coming from the iliac crest bone graft harvest. There are some tricks to doing it. We do go sub-iliacus, and we have the patients on crutches touch weight bearing for 6 weeks after, and then progressively get them into pool therapy, and that it's a full 6 months before we really have a success or failure. Another key point is when you elevate the iliacus, when you reattach it, you have to attach the iliacus fascia over the sacral brim to the gluteus fascia, or the iliacus will slip down and you'll have muscle weakness because of the link tension relationship being altered. And so there are a number of key approaches to that. And Mark was doing a number of SI fusions and quite frustrated with them until I started doing the minimally invasive triangular titanium rods. And we decided to work together on the revisions since they were challenging enough that neither of us really wanted to own that population by ourselves. But together we decided that it was doable. And we've had the opportunity to revise a number of different implants and a number of different strategies. And I can't say that there's one size that fits all. And your comments taught me about thinking about the caudal aspect of the joint. And so I've had, I think, 6 patients now who had well-fixed implants, but still had pain that was relieved by that caudal injection. And so in those patients, I've delivered a navigated K-wire, then typically like an ACL reamer or something like that, and drilled out the joint, and then done impaction bone grafting alone, and had a number of them get significantly better. And it's sort of like, okay, why does that work? And as I thought about some of my failure patients, I always figured ankylosing spondylitis or the spondyloarthropathy patients would be the best candidates for fusion because they're going on to fuse it anyway. And what we're doing is trying to accelerate it. But then I started thinking about it, and what they're doing is they're reacting to their own articular cartilaginous surface. And so if we haven't eliminated the cartilage and it's an inflammatory pain generation, then they're still having their own autoimmune response to that intact cartilage. And so that's where the thought of trying to clean out more of that cartilaginous surface. Now, these revisions have not been in that patient population, but that's what got me thinking about it and made me say somehow maybe there is differential sacral motion between the S1 segment and the more caudal segments where sacrotuberous and sacrospinous ligaments originate from, and that it's got the differential deflection in the caudal aspect of the joint. I have no idea if that's an accurate statement or not, but it's been sort of my attempt to try to understand it and to come up with a thoughtful approach to how to figure out where they're hurting and why are they hurting and what could be done about it. And I blame that approach on you, Vic. So.
Sorry if I got you thinking too.
Credit. I should say credit.
Well, great. Thank you. That's very interesting. Does it change at all your thought as to, do you have to graft from the anterior approach every time, or do you sometimes say the anterior approach is too much and I'm just going to graft from the posterior approach?
Well, we have told some patients no. So like you, if they are not nicotine test negative, I won't do an elective revision on them. Just won't do it. You got to stop smoking because that makes more of a difference probably than my surgical technique. And then there have been some folks guys with just too big of a beer belly that Mark Swinkowski looked at them and said, I just don't think I can get there.
Right.
That BMI was probably in excess of 45.
Oh my God.
Right. And it's all in the gut. Right. And so it's just like, can't get there, can't do it.
Right.
And so those have been we can't get there. But otherwise, if the implants are loose, then our thought was our most likely chance to get the best biology was that open approach and autogenous iliac crest bone grafting. And you get maybe the upper third to upper half of the joint is all you can reach. So you're really getting sort of the S1 down to maybe the S1-2 disc space segment is really what you're getting access to. So I mean, that's sort of what our experience has been. And I'm not advertising it as a end-all be-all solution. It's just sort of in our journey of struggling with this with a not insignificant number of challenging patients, that this is what we've gotten to. And Mark was excited about us looking this up because it's a whole lot of work. I mean, it's about 4 hours of surgery to do this with the two of us. Mm-hmm. And if we're not making a difference, we'd be delighted to stop and do something else and send them somewhere else. So
right. especially considering the reimbursement for those 4 hours, right?
Yes, yeah.
But
It looked like Bengt has a question, maybe?
Yes, I want to have a comment on that of anterior surgery. I have been very afraid of anterior surgery on the sacroiliac joint because we had in Sweden a professor, Sven Olerud in Uppsala. He made a lot of anterior procedures. He started with fractures. And he had good outcome, but then he started to operate on pain patients with sacroiliac pain, and this was in the 80s. The problem was that with his procedure, he had to move L5 nerve, not to make damage on the L5 nerve. And more than there was a friend of mine in my same age who tried to follow these patients up. More than 50% were in so bad condition because to touch the L5 nerve, it was really bad. And they had a continuous pain, and then the pain increased. I was thinking about that when I saw your figures, Paulie, because the outcome was not so good in the long run. And
Yeah, so
increased
right.
pain. Is it the L5?
Yeah, so
Leg pain?
so Mark is very, very skilled at doing this. And originally when he was fusing them anteriorly and plating them. And to do that, you really have to retract the L5 nerve very much medially. But with the iliosacral screw fixation, he's not really retracting the L5 nerve very much. And so your comment about is it an L5 nerve root pain? Not typically, but maybe for some of them. And so that's a great point, Bengt, and that, you know, that it's not when you know how to do it, the approach can be done with low morbidity. When you're learning how to do it, you're probably going to hurt a number of patients. And so that's why I just decided I wasn't going to learn how to do it, and Mark did it very, very well. And so he does. I worry about the other stuff, and he worries about the anterior approach. And so about once a quarter, we're doing, you know, typically 2 patients at a time in one day, and it's a long day. But that's a great point about the L5 nerve root.
Are there any other questions? And if not, I have a few. Okay, the first is, I've done both posterior and lateral approaches, and on some of my lateral approaches, these patients have either a superior gluteal nerve dysesthesia or some fascial syndrome or muscular syndrome over the impact site. And it's not severe and it's not frequent, but I'm just wondering if either of you have experience with that.
Yeah, so I've seen a number of people with superior cluneal nerve neuromas that have just been exquisitely tender. I mean, I learned about that as a resident. We took posterior iliac crest bone graft, and that was the question that my teacher, Bruce Van Dam, always said, okay, so what's at risk here when you're doing this? And then I've learned to look for that. I haven't really learned how to personally treat it. I know that you can cut it and bury it in the fascia. I've sent a couple of patients for that, and they didn't get any better. And currently, Ralph Rashbaum and Texas Back Institute has been using the stem wave peripheral nerve stimulator for these cluneal nerve neuromas and getting a pretty good response to that. There's a nice paper by Maine from France talking about as the cluneal nerves come out through the fascia, that there can be entrapment there, and that sometimes it can be an example of L1 or L2 root pathology, and has had discussions about that. But I've been distinctly unhappy in my personal ability to treat it, and I see a couple of patients a year with it, and my pain folks and my peripheral nerve neurosurgery colleagues don't really have an answer for it. And so I've literally sent a couple of people down to see Ralph for a peripheral nerve stimulator.
So these fascial syndromes, you see them once or twice a year?
Well, I will say I see the neuromas, and
Yeah.
whether it's from the fascial outlet, and some of them have had minimally invasive paraspinal approaches, and I think I've probably caused one or two of them from putting in percutaneous reference pens for navigation, and so I think there's a variety of ways to injure or irritate the superior cluneal nerve, and I don't have a lot of great answers about how to fix it once you've irritated it.
Okay, and the next thing is Vic threw down the gauntlet, saying that you had to fuse to be durable, and there's a competing underlying story there about whether the lateral approach is actually a fusion versus a stabilization at two ends of a device. So Vic, you were saying there had to be a fusion, and David, you've been advocating not to have a fusion. Could you just support either approach, each of you?
Well, I have no gauntlet to throw. so I certainly am not adamant about my recommendation, but my experience has been that getting bone graft into the joint and decorticating the joint has been beneficial in my patients. So I do believe that even with a really nice stabilization with the SI bone technique with the 3 triangular implants, having that bone graft in the joint is an added security measure for me. And I suspect that it's avoided long-term complications in a lot of patients of potential loosening. So it's become a standard of my practice, but I don't have evidence or data that it absolutely is better.
Yeah, so Tom, I guess my approach to it would be to say to you that the best data that we have comes from the RCTs of operative versus non-operative treatment, and that then we get into religion instead of science, and that the majority of the patients do well with the procedure, and so then what is the added cost of the intervention, and I don't mean economic cost, but morbidity, mortality, et cetera, of doing additional bone grafting. And I think in skilled hands, it can be done well. The first time I used the Zyga decorticator was an attempt to salvage a failed implant from another device, and I broke the decorticator in the joint. And I said, I don't really want to have that experience again. So I've not done that as a routine part of my practice. When you get to a salvage scenario, then I think it's a different calculus, if you will, than in a primary. And so if we have, pick a number, 85% good results with a primary procedure and appropriately selected patients, I'm probably okay with that. And then you say, what then is the incremental benefit? Vic has the advantage of, in his community, he can use RHBMP2 off-label, or at least he was able to in the past for this kind of thing, which I think decreases the morbidity of the fusion effort. In my community, we have trouble getting to use RHBMP2 on label, and that all of the commercial payers will preclude us from using it in any off-label application at all. And so I can't really do that. So I'm a little bit hamstrung, if you will, in my ability to do that part of a thing. In a perfect world, if I could do that, yeah, that'd be great. But I have no data. And if we were to try to design a comparative effectiveness clinical trial, would the power analysis, in my best guess, is it's probably, what, 1,000 or 2,000 patients in each arm in order to show a difference. And so I think the probability that we're going to get to meaningful comparative effectiveness, high quality research on that particular topic is low.
Okay, thank you. Are there any other questions?
Yeah, I have some more comments. Well, I am, I live in a very special situation. In Sweden, I'm almost the only one to do a sacroiliac fusion. So I have full control. So if I have any problems, they come back. interesting thing. I checked for my first generation of IFUs. I have about 2% of revisions. That means 7 or maybe 8 patients. With the 3D, I done about 200 3D something, and have no revisions yet. But it is only 2 years that I used the 3D, but it is quite different, quite better. But then I do revisions. I have only done lateral revisions, and what I asked for from the beginning was what do the people do in the United States when they do revisions? Because then I had some answers, and so I started to do this David Star. I mean, I removed the loose implant, rotated the brooch, and make a star of David and put bone graft in. But it is quite simple to take bone graft from the ilium, and I think that was a really good treatment, and I've used that in those cases as well. I'm also traveling. I've been in the Netherlands and helped them, because there was typically in the Netherlands we had a guy who put 2 implants on every patient and started to ambulate them immediately, and there's a lot of problems with those. So I have been there and doing adding 1 implant and put a star of David on the others with bone how to say replacement, bone grafting. It was good outcome actually, and I have not have any problems yet. And then, on the other hand, I have not done this very scientifically, because there are so few patients. As I never did any science on my first 50 open cases I did over 15 years. So because if you do 1 or 2 cases a year, you can't do science. But with the open cases, I had a lot of, 10% of cerotrosis. And out of them, I have operated now 4 with IFUs. Quite tricky because it's very hard bone, but they all healed out. So it's not very simple team. I really liked Vikas. You put on the biology, nicotine. Never operate on nicotine patients. I heard about big patients. I think the highest, and I don't like BMI 32. It's too much, really. I want to keep them under 30. And because if you put too much load, I think the outcome is not good. And then use crutches. I use crutches, and the patients are happy with that. But the good thing is to discuss revisions, I think, because what to do when you have a failure. And if you are sitting somewhere and have nobody to ask, you need to know where to send the patient. In US, there are some places that you need to know what to do. And I think that this forum, to have discussion about how to take care of failures, I think it is really, really good. So thank you very much for starting these discussions.
Excellent. Thank you very much. Are there any other comments? Okay, well, it looks like we've lost David, and Vic, thank you very much. And
Thank you.
Thank you very much.
Thank you.
thank you.